Welcome to SEVA VentRounds. This is a re-recording of our original transmission of a very interesting case of NAVA done on May 2nd, 2023, but due to audio issues, we had to re-record it. We will discuss particulars of ventilator modes, no endorsement of any particular mode manufacturer or company. Whatever we say, it's our opinion. It does not represent the Cleveland Clinic's. I'm Eduardo Mireles. Those are my disclosures, and Rob Chatburn was involved on the initial taping of this SEVA VentRound. To begin, we'll start with a little bit of knowledge. When the signal comes out of the brain to start a breath, it travels through the spinal canal and the nerves all the way to the muscles to achieve the contraction. Now we have the ability to see the electrical activity of the diaphragm by means of a catheter that we use for NAVA, and that's what's called electrical activity of the diaphragm. And you can see it here. This is a curve that has been smoothed out from all the signal that comes from the electromyogram, and it gives you this signal where you can see the start and then essentially the end of the breath. In NAVA, it starts 70%, it ends 70% after the peak. But just to put in images for you where the breath starts and ends. After the electrical activity of the diaphragm is occurring, you would see contraction of the muscle, and that should happen relatively fast afterwards. And this would be manifested. Now we have the esophageal catheter with a drop in the pleural pressure. And so you can see here the start of the drop in the pleural pressure, and then the end of the peak of the drop of the pressure in the pleural space. And that would lead to changes in airway pressure and flow, which you would see on the signal for your airway. And in that case, the breath starts here and ends all the way over here. And if you had the ability to measure the difference between these numbers, you have those dashed lines and the numbers on top, you can see the difference between the electrical activity of the diaphragm start and all the way to the difference when it actually starts on the ventilator. So the difference between 1 and 3 is the lag from the electrical activity that starts. And the same, the difference between the peak on the electrical activity and then the end of the breath over here. So that's a much more finer way of measuring differences, but also if you're controlling the ventilator, and now instead of having to cause all the changes on airway pressure and in the pleural pressure and then on the airway pressure, you can imagine that it would be more responsive and that synchrony lag would be gone. So let's see this case that we had. And we start as usual by defining just by looking at the waveform. I'll give you a couple of seconds to look at it and think about what's the tag, what is the load, and what's the patient ventilator discordance. And you can pause it here and take a look at the image. All right. So in terms of tag, what we do see on this waveform is the pressure during inspiration is flat, and the flow actually changes between each one of them. You can see the difference between the last breath, the second. And so this tells us that this is likely pressure control. And actually we have it up here, but it helps always, remember these are commercial names, and sometimes you don't know exactly what they do. So pressure control. All the breaths are mandatory on this pressure control, so they're being triggered by the patient. You can see here the changing color, and then they're cycled by time. And you can see that the flow was still ongoing into this patient at the end of inspiration, and then it cycled, and all the inspiratory times look the same size. So this is CMV, so continuous mandatory ventilation. And then because in pressure control, you set the inspiratory time and the inspiratory pressure, this is set point. So you put on, you are the one that ruled and put on all the settings for the machine, which is set point. In terms of the load, it becomes evident during inspiration there's triggering, and there's some deformation on the inspiratory flow, and you can see it probably a little bit less change here on the flow is more decaying, but it's taking a long time to get to baseline, and that tells me that this is likely resistive. And if you see the expiratory flow, it's exponential, and it's taking a long period of time to reach baseline on the 3 of them. And so this is likely a patient with very increased resistance. In terms of patient ventilator discordance, when you see this waveform, you can see that there's a drop in the pressure at the beginning of the breath, but it's not mainly major. And I'm inclined to call this normal. I don't see any failed or false triggers. I don't see it to be late or early because all the breaths are triggered by the patient. In terms of inspiration, I see a little bit of PMOS during inspiration. You can see instead of having that normal decay, you see an amount of PMOS, but it doesn't look particularly evilish. It looks actually perhaps normal. And in terms of cycle, I don't see features of early cycle, and I don't see the patient was not even reaching end of flow, so I would say that this is likely normal. And in expiration, we could argue that there is some effort, but I don't see much. I would say that this is probably a passive patient, and so I would call this normal. And at the bottom of these waveforms, you have some amount of leak. You see the discrepancy between inspiratory and expiratory. So I would say that there's a leak. And on the last, you have the time-based capnogram, and it has the classic shark fin, which would tell you that there is obstructive disease. And so if I walked by and I saw this waveform, I would likely say, you know, pretty severe obstruction on the patient with very severe resistive load, with a small leak that you may consider to deal with or not, and an obstructive pattern on your capnography. So that's probably what I would have said, actually what I said, because I did see this patient, but now I'm going to disclose to you, and your eyes will become more privy to a lot of other data. So what you have here is the actual waveform, but now it has over it the overlay of the electrical activity of the diaphragm, and this would be an estimate of the amount of pressure that the ventilator would be delivering if we activated NAVA at the set NAVA level. And what you see here is the breath, there's electrical activity of the diaphragm, and you can see that the actual electrical activity started right here, and the breath started all the way over here, right? So there is a good amount of discrepancy in the amount of time. And now if you see it, you will start, your eyes become evident. Oh yeah, I can see that it was dropping the amount of pressure down, and you can see that the flow was actually approximating the baseline, and it becomes even more evident on the next breath. And the third breath, you can see how it actually reached 0, but it didn't cross over. So now with the aid of the electrical activity, you can say, well, there is a good amount of delay from the electrical activity of the diaphragm and actually the triggering of the ventilator. So these changes, I mean, the reading, it's still at PCC-MBS because we didn't change anything. It still is a high resistance. But this has changed to being a late trigger, because it's taking a fair amount for it to come, and it's all because of that increased resistance, and it becomes, this is probably the best example. You can see how the flow starts going up during all this period of time. It reaches baseline and it doesn't cross up. So now this has highlighted a late trigger. Now during inspiration, this is probably the favorite part that I have for this. So I want you to notice that the patient is doing a lot of effort, the effort here. And all this period of time over here that I'm shading, there was no support from the ventilator. The same over here, all of this activity was minimally supported from the ventilator. And in the last breath, actually the patient even cycled and never got support from the ventilator. The support, the maximum support that you were thinking that you were giving 28 was being given all the way over here, all the way over here. So all this area over here was stuff that we were supporting. Now we were now over assisting the patient on the other side. So this is a patient that was getting actually under assistance. And just to give you an idea, when this patient had been on high doses of sedatives to be able to be ventilated, because every time they stopped it, the patient would start having very hard work of breathing. Even though synchrony looked good, as you were seeing here, the patient didn't look good, and that's why they had been continued to sedate until he got a tracheostomy. You can see now that the cycle is definitely, the machine is cycling early compared to, it's cycling late compared to the patient. So the patient breath ended here and the machine ended all the way over here. And we don't, this machine doesn't allow us, the EDI doesn't show you activity during expiration, but there's no expiratory work. So by using the electrical activity of the diaphragm, our clinical diagnosis, just by walking by, saying, oh, the patient was completely synchronous with this, changes to a patient that has a severely under-assisted work, even though it's generating appropriate large tidal volumes, even though the waveforms looked fairly good. So we activated NAVA, and now you can see that for each breath, the pressure waveform will look, because it's proportional to the electrical activity of the diaphragm, you will see the electrical the pressure will mimic the electrical activity of the diaphragm. So this waveform down here, which is the electrical activity of the diaphragm, will look like this one over here. And now the patient is getting, it's being triggered at this time. Actually, this is a good image. You can see the changing color. It's being triggered by the NAVA signal and cycled by the NAVA signal. And for each breath the patient activates, it pressurizes and it gets the tidal volume. So if the patient does more effort, so you see here a higher effort, and here you see lower effort, and you can see that for lower effort there's lower pressure being delivered to the patient. So now synchrony was achieved, and you can see how that actually looks better in terms of synchrony. The patient became much more calm, and we were able to essentially stop completely all the sedatives for the patient and bring him back to earth. I'm going to show you this other graph that I think that it's very, very effective for us to learn. And I'll just walk you through it. And the reason why this is very useful is because the ventilator has a set of rules, and even though it has the electrical activity of the diaphragm down here, it has a rule that says that if there is a change, that if the flow reaches threshold first, it will trigger by flow, as you see here. And if the EDI reaches threshold first, then it will trigger by the EDI, as you see down here. So you have two breaths that are triggered by by flow, and one breath that is triggered by the EDI. And the good thing about this is that then you can compare actually what happens to the pressure. So you can see that the pressure in the airway before the breath drops in the first two breaths. Even though afterwards it follows the activation of the diaphragm, you can see that there's some inefficiencies from the flow triggering that we know that happens on this patient because of severe obstructive disease. But if you see that the last breath, you can see that that inefficiency goes away. You barely see any drop in pressure during inspiration, and the flow just matches what's happening during inspiration over here. So a good example of, even though you're using a very sensitive threshold to activate the ventilator, it is evident here that it's much more efficient to trigger for this patient and use less energy that or less work of breathing that the patient needed. And so, and again, it also shows that if you capture a small EDI, so a small effort by the patient based on the electrical activity of the diaphragm, you would have a little bit of pressure delivered, which in this case equates to very small breath. And the next one, the patient generates more, and you can see how it generates more pressure and more volume. And the last one generates even more area under the curve for the electrical activity, and it gets a much larger tidal volume. So this is NAVA, a very nice example of neurally adjusted ventilatory assist for this patient. And I will tell you that the outcome of the patient is that eventually it was placed on trach collar and was sent for further rehab in Ames to get him to a level where transplantation would make sense for them. So here it is. Please send us your waveforms either via Twitter or by email to either Rob or myself, and we're happy to work on these and discuss at our next SEVA VentRounds. Thank you very much for joining us, and looking forward to see you in our next SEVA VentRounds.